Is Simon here?
Not yet.
Okay. Did you send him the new link as well?
No, the link is the same.
That's not the one that was on mine when I pressed it from iLearn.
No, it's the same. I got it off
No,
iLearn.
I manually entered it and it was different.
Oh.
Oh, really?
Mm-hmm.
I don't know, mate.
I manually entered it twice. So from the email you sent me, I entered it, and I entered the one from iLearn, and that was the one I kept getting booted from.
But I'm guessing that everyone else entered from iLearn. Is that correct?
I did, yeah.
Yep.
Okay, so that's weird. So on iLearn, yeah, it was different for me.
So I know that I'm trying to read what you wrote, Sebastian, but I can't get the first word, man. So I know Simon is not. He's not at home. He's trying to use remote desktop stuff or remote internet, and so here he is. His name's there, but I can't see him.
Yeah, Simon's saying he can't get in either. So he's doing the same thing that I did, I reckon. Do you want me to tell him to look in the Outlook? I'll send him a message.
Yep.
On a side note, this has happened all week. This is not just today. This has happened to me on Zoom all week.
Oh.
Like I just spent 2.5 hours on Zoom this morning. Then I upgraded after that between 1 and 2.
Yeah.
And then that's when it's all gone pear-shaped.
Yeah, I upgraded today too.
Yeah. And so it says Simon is logged on.
Yeah, but he's doing what I did. He's in that other weird link. Let me just send him the... Where did it just go?
So guys, what I may do, we may get started in a second. And then when Simon gets here, I'll move some people into his thing.
Why don't you create 3 breakout rooms anyway, Chris?
And then I'll jump in one, and I can swap Simon.
Yep.
All right, let's do it. Who's recording today?
Me.
Thank you, Rach. Let's do it.
Hey, Chris, am I a co-host?
Oh, he's here.
Here we are.
1 second.
Zoom had its moment this morning.
Yes, Zoom. Going good. Yep, you're a co-host, mate. Everyone's co-host. All right, beautiful. So, the goatie's here, Simon. Look at you. You have a follower. All right. All right, are we ready?
PowerPoint's not opening. Give me a sec.
Yep. It's one of those kind of days, guys.
The joys of technology.
Yes. Well, hopefully, this is, the second last week we have to do this online, which is bloody amazing. I don't know who else is excited, but I am.
Except for the lectures, though.
Yeah, well, lectures are fine. But shoots, mate. Jeez. Can't wait to just start touching people again.
You love it, eh, Chris?
Mate, that's why
not weird at all.
Mate, jeez.
Chris, can you see that waiting room?
Yep, I'll get it. Who is?
I don't know. That's what I'm saying.
Let's have a look who it is. I don't know. Where is that name? I've got no idea who that is. In your chat room, can someone find out who Nanny2 iPad iOS 11.3.1 is? Okay. So, guys, if you've just turned up, can you please say hello on the chat, just so we have a record of who was here, and we're going to move into our rooms now. Okay.
PowerPoint's not opening.
Hi, Rachel.
I'll leave, hon.
As always, if you have any questions, please.
You're already there. Just click join. Rach, what are you doing here? Hello, Rachel. Unmute yourself, darling.
Oh, I was in the same room as Beck, so now I'm going to room 3. Here we go. Hello. Can everyone hear me?
Yes.
Hi. Sorry,
Yep.
I got put in the same room as Beck, so I had to get back again. Okay. So we haven't got as much material to get through today as we did the last couple of tubes. Does anyone have any questions before we get started? So everyone's feeling super confident, super pumped. Beautiful. All right, let's get started with this first. So the people who were in my group the other day, we didn't get to finish that slide, so it'll be a bit new for us, but for everyone else, they've done it. But it's all pretty self-explanatory. All right, everything's super, super slow. I don't know, we all did this upgrade today, so I'm going to turn my video off, see if I can make things run faster. Okay, if there's any problems, let me know. Come on. Okie dokie. So remember we started going through this all the other day. So if this, say, was an exam question, so I'm going to need some contributions from everyone today, all right? So when we're looking at that first column, that star diagram, that is an indication of what?
Flexion restriction.
Yep. In what kind of range of motion?
Global.
Right. Okay. So does everyone agree it's a flexion restriction? Yeah. Okay. So the dash diagram for a flexion restriction is exactly the same, right? So in our segmental ROM, what does that mean?
Flexion restriction.
That's right. Now, these last two columns refer to what we would find, okay? So remember we talked about where our contacts would be and what kind of findings we would find. So like, what are we actually feeling with our fingers? What is the bone actually doing? What are we actually assessing? So for our seated end feel motion palpation, what do we have?
That's not tested.
That's right. Good trick question. We don't do a seated end feel motion palpation for flexion. Okay. So, there it is.
Rachel,
Okay.
just to let you know, we have all of these filled out in our PowerPoint.
Oh, what?
Yeah.
Wow, this is the way Chris has given it to me. Okay, well, so just try to see if you can go through it with me then. If you know the answers, this should make it easier, right?
Yeah.
So for our seated segmental end feel range of motion, what are we doing? Sure, what's our contact?
Is it the interspinous spaces?
Yep, okay. And so what should we be feeling?
Separation of the spinous processes.
That's right. So if they don't separate, what have we got?
Approximation.
Well, not even approximation. It might not move at all.
Oh, right.
So if it doesn't move, what do we get at the end of all of this?
Flexion restriction.
Restriction. That's right. So I want you to kind of tie it back in all one big loop, okay? So you go, okay, well, these are all my tests I've done, which are giving me a flexion restriction. But when I'm actually feeling it, I'm going to be feeling for those spinous processes to separate. If they're not separating, then I have a flexion restriction. Okay? So the next one's easy. So it's global range of motion in what restriction? Right rotation, that's right. So our dash diagram indicates what segmentally?
Left rotation.
What kind of rotation? Be specific.
Feet away.
Feet away, that's right. Okay, so for our segmental end field, what are we going to get?
So when we say segmental end field, right, you're going to say, where is your thumb on the SP and what direction are you moving?
Yeah. Does that make sense? So remember we talked about this before. What's our contact points? What are we actually going to be feeling? And then, because that's how we get to what those listings are. Okay. So for a left P to A rotation, where are we going to be putting our hands?
The thumb on the right side of the spinous process.
That's right.
Good
Okay.
job, Hannah.
Yeah. Okay. Are you getting this now? And for our seated segmental range of motion, where are our contacts going to be?
The
Spinous process. The spinous contact.
That's right. What side?
The right.
That's right. Okay. And so then we're feeling the spinuses do what?
Moving to the left.
That's right. Okay. Can we all tie this together now? So for our next one, it indicates what on the global diagram?
Right lateral flexion restriction.
Okay. And then in a dash diagram, so our segmental range of motion, what does that mean?
Right lateral flexion restriction.
Yep. So it's easy, right? So when we're assessing, oh, that came up too quickly. Our seated end field, where is our contact going to be? If you're assessing right lateral flexion, where would you contact?
On the right side of the SP.
That's right. Okay. And so then what are you feeling for?
Spinous process moving to the right.
Yeah, that's right. Okay. Is everyone following this now? Good. So you can see where Chris is heading with these exam questions, right? Being able to tie it all together. So our last one is what? A restriction in our global range of motion.
Extension restriction.
Action.
Okay, so easy one. And our dash diagram looks the same. Which ones are our dash diagrams different for?
Rotation.
That's right. Okay, so our extension restriction, our segmental range of motion is going to be extension. Now, what's our seated end field motion palpation? What's our contact?
It's the P to A motion palp into extension.
No, it's from when, yes, yes, that's right. So yeah, it's that, so don't include the P to A, just include the fact that you're doing it as an extension.
Okay.
Okay. And then pisiforms on our SP. Okay. And then the last one is our interspinous contact, because you're doing it at the same time as you do what? So you would do one movement first, which has the same contact, and then you would do this one.
Flexion.
Yeah, that's right. And so what are we feeling the spinous processes do?
Come together as we extend.
That's right. Okay. Is everyone feeling good about this now?
I wouldn't say good, but
Okay. Remember, as I was saying, visualize it any way you can. I use my hands still to this day to make it do the spinal anatomy. Even today, when I was going through stuff, I got one of my kids to stand up just so I could actually feel it with my hands because it makes more sense. But if you try and follow the pattern and get it into a system and say, right, well, you know, the same way you practiced your peripheral work, you're saying, I would put my contacts here, and then in your head be like, what am I going to be feeling? What is that vertebra going to be doing? And then you'll be able to approximate the listings after that. Okay. Come on, little slide.
So Rachel, really, if you remember where your contacts are supposed to be, then you can kind of think logically like, okay,
Yeah,
what
that's right.
would, okay.
Right. So it's a matter of understanding what you're supposed to be doing and what you're supposed to be feeling. So whereas when you're in a practical class, when we're in actual touching people, you can feel that yourselves. So it kind of becomes a little bit easier. This way we're going the other way around. So we're going to be doing our 2 lumbar adjustments today. We have a bilateral inferior, a BLR inferior, and we have our pisiform contact anterior. Now, the setups for our lumbars, we've got a generic setup here, okay? So in terms of these are the things that apply for every setup, okay? It just changes what you're going to be doing. So to start preparing, we do our tissue slack. So our tissue slack is always in the direction of our line of correction. LOC stands for line of correction. So for a BLR inferior adjustment, what would be our line of correction?
Doesn't it depend on which segment you're assessing because of the lordosis?
Not because what kind of adjustment? It's got it in the name.
A lumbar?
Inferior.
Okay.
So the adjustment is an inferior adjustment, so the line of correction is inferior. Okay. So Chris obviously went over the lumbar roll position with you guys in your lecture. Yes.
We didn't have a lecture with Chris today.
Oh no, but haven't you done these the other day? Last week?
Probably. I can't remember.
Okay, so the BLR lumbar roll position basically refers to that side lying position that we put a patient in, with them laying on the point of their shoulders, arms crossed across their chest, the top knee is bent, and the spine's in neutral. The patient basically should lay kind of across the table from the point of their shoulder down to their opposite foot, okay, in a diagonal line. So that's the standard position that we use, and then we alter that position depending on what adjustments we're going to be doing. So the patient's in that lumbar roll position, practitioners on the side of the couch. Normally you want to kind of be around about their pelvis. That's how far up the couch you want to be if you're doing a lumbar adjustment. And you're normally going to be facing in the direction of the line of correction. So if it's an inferior adjustment, you're going to be facing diagonally up, cephalad, up the couch. Now, when we do our lumbar roll, one of the reasons that we do it is because we want to be able to roll the patient as a whole unit to be able to get our center of gravity over the top of where we need to be. So remember, for all of our adjusting, whether it be peripheral or spinal, we always want to have our center of gravity in the most effective place. Okay? The chosen stabilization method is applied. So does anyone remember what 3 stabilization methods there were? Is this ringing a bell for anyone? Okay, so the stabilization refers to how you're going to be stabilizing the patient's lower half with your lower half. So we either have a thigh sandwich, we either have the hip to hip method, or we have a thigh to thigh. Is that all ringing bells now?
No.
No, I'm the same.
I'm pretty sure it's in your notes, and I'm pretty sure it's all on iLearn. So if you want to have another look at it. The doctor is to have their knees slightly flexed in a fencer stance and their feet are pointing parallel to the plane line of the drive. So you'll be able to see, you don't want to be kind of twisting your own lower body. You want to be going in one continual line of force. That's because we have a body drop for these lumbar adjustments. So we need to be able to make sure that we're getting the most effective movement possible. So the primary hand is going to be, let me go to the secondary first. So the secondary is the same for all. So the secondary goes onto the patient's shoulder, and you're going to be applying a superior and slightly posterior direction because you're going to create tension with that secondary. Okay? So the primary hand depends on whether we're going to be doing an assisted adjustment or a resisted adjustment. Does anyone know what these ones are today?
Assistive, isn't it?
Yeah, they're both resisted today. So what's the difference between assisted and resisted?
Assisted is it's in line with the tension, like it's in the same direction as the pre-tension.
Yep, that's right.
And then resisted is away from it.
Okay, and what else does it mean for contacts when we have assisted or resisted?
Assisted is like you're contacting the joint above, or you're affecting the joint above, and then the resisted is you're affecting the joint below.
Yeah, so with your assisted adjustments, you're going to be affecting the joint line below. So your primary contact is on the joint that's listed. Okay? Mm-hmm. Whereas if you are doing a resisted adjustment, the primary is on the joint line above, and you're pre-tensioning it in the opposite direction, but your primary is on the listing below. Oh, LOC, line of correction. Shiva, does that make sense? Got it? Okay. So then for our BLR inferior adjustment, which we know is a resisted adjustment, our contact is going to be where? Above or below the listed segment?
Below?
That's
Below,
right.
yeah.
That's it. Okay, so our primary is going to be below our listed segment, dragging the into tissue slack in the line of correction, which we already know is what direction?
Inferior.
That's right. Our secondary is going to be creating some torque by pushing the shoulder superiorly and posteriorly. And then we've got hip flexion. Okay? So those are the things that make up an intersegmental lock. This is what makes your adjustments specific. This is what makes sure that when you put a force through, that every single spinal vertebra doesn't go pop, 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 pop. We only want to hear one pop. Okay? The reason being, we want to make sure that we can control what we're doing and make it safe. Okay? Everyone understanding that? So the primary is stabilized and loaded via a weight transfer in the direction of the line of correction. The thrust is a sharp thrust applied by the primary going in the direction of what?
The line of control.
Line of correction. What's the line of correction?
John,
I confused you. I'm sorry.
I like line of control. That's right, inferior. Remember, again, all of these things are not trying to trick you. If it says inferior, that's the way you're going. The secondary must be maintained as a stabilization point, and you don't thrust with the secondary. So it's not a scissor. It's not a push with that secondary. It's just a stabilization. Okay. Have I completely lost you all yet? No. Good. As long as this PowerPoint doesn't have a conniption, we'll be fine. More chats. Jessie needs coffee, does she? That's right, I think we all need coffee. Come on, little slide, move along. Okie dokie. So here we go. These beautiful pictures. So we can see Steve standing in his fencer stance. You see his feet are parallel and is going to be in towards the line of correction. Okay. That is our beautiful BLR position. That person is rotated a little bit too much. We want to have them more in neutral when we start, and then we rotate them anteriorly. So you see how that the foot that's off on my direction side. So that she's laying with her right side up, so her left side is down. Her left foot is off the edge of the couch. We don't want to have them in the middle of the couch. We want to have them on the edge there. And she's laying on the point of that shoulder, and her hands are clasped across her chest or abdomen. Okay? And here we can see the setup position for this lumbar BLR inferior. So you can see Steve is pushing that secondary just superiorly and posteriorly, creating a little bit of torque. And then that primary contact is going to be, we'll talk about this specifically. Okay, so with our BLR inferior, what kind of adjustment is this? Is this a short lever or a long lever adjustment?
Is it a long lever? No, short lever.
No, it's a long lever.
Uh,
Okay, so just look at his arm. It looks long.
yeah, that's what I thought.
Yeah, it's a long lever adjustment. So for our long lever adjustment, what is our contact on the practitioner's point of contact? Like not on the patient, but what part of our body are we using?
Soft pisiform?
No, that's a short lever.
The elbow.
No, you're not using the elbow. You're
Aren't you
absolutely.
twisting them?
Is it the forearm?
Yes, it's a fleshy forearm
Yeah,
contact.
yeah.
So basically you have your hand fully pronated and you have the fleshy forearm. So if you're looking at your own arm, it's basically that chunk of flesh before your elbow. Okay. Now, when I say you need to have your arm fully pronated, because you want to try and keep the ulnar border off the patient. Okay. Does that make sense? I'm doing a lot of hand movements here because, that's just the way I work. So I better turn my video back on for a sec. So you're going to be using here. But you want to make sure your arm's fully pronated because you don't want to be getting that ulnar edge on top of any of the patient, okay? Because that is like bone on bone. That's going to hurt. You're going to be grabbing it through here, okay? And now, for this particular adjustment as well, you're going to have a standard contact, which is going to be on the patient, the sacral alar. Okay, so even if the segment you want to adjust is at L4, you're going to be dragging the tissue slack anteriorly and creating that soft tissue bridge between L4 and the alar. Does that make sense?
Can you explain that a little more, Rachel?
Okay, let me see if it's on the next
Sorry.
slide. That's all right. No, I know. I was flicking between your notes and things today. Okay, so it doesn't show it on the slide. Okay, so between L4 and the sacrum, so it's a resisted adjustment, so we're in a segment below. As you create some torque with the shoulder and you take the tissue slack superiorly to create that kind of resisted adjustment, as you then pull inferiorly with your primary, you're creating a tissue bridge as you stretch all those soft tissues. So then as you take your force inferiorly, you will create that cavitation at that joint.
Oh, okay.
Steve will show in the video how you do an individual joint lock so that you don't lock up every single joint. Okay. So for our BLR forearm contact inferior adjustment, we're talking about our adjustment biomechanics. What else could we include in this? What kind of recoil does this adjustment have?
It's a slow passive recoil.
Yeah. So what's the difference between a passive recoil and an active recoil?
Isn't active, you kind of just let the muscle recoil itself, and passive, you kind of guide it?
Yeah, and it's also the way that you thrust as well. Okay, so are you basically forcing your arms back up quickly, or are you just letting your arms come back up slowly? So as you recoil, as you let go, what happens then? Okay, let's go a little slide. Okay, so let's get all this up so we can have a look at this, because I'm sure you've got it in your notes too. So if it's an inferior adjustment, what are we correcting? What kind of restriction?
Flexion, lateral flexion.
Lateral flexion, okay, because inferiority, RI or LI means inferiority to the right or the left, which indicates lateral flexion. Okay, so just say for this patient that's laying on the table, their right side is down and their left side is up. So what is the listing?
Left lateral flexion
no,
restriction.
So it's an L direction. What side is the lateral? If we had our global range of motion here.
Flexion.
Yep, that's right. So we're correcting adjustment to correct that. So see how you could follow this back on. So if you say, okay, I'm going to do this, do my assessment. I come up with a listing and I tell you what kind of okay, so here we go. So this makes it more sense with the tissue bridge, okay? So you can see, even though the listed segment, and this one is like L3, LI, you can see that by pre-tensioning the tissue, the secondary superiorly, and then taking that primary contact inferiorly, you create that tissue bridge, that pre-tension. Okay? Now let's watch Mr. Esposito do this.
The adjustment I'm about to perform is a BLR inferior forearm contact inferior thrust. With all long lever adjustments, the aim is to create a soft tissue bridge from the segment that you want to adjust to your forearm contact. It allows you to increase the lever arm and to increase the amount of force you want to use. Likewise, its major aim is the ability to use traction. As described previous, the lumbar roll position requires the spine to be neutral and running from the top corner to the bottom corner of the couch. With the forearm contact, our primary contact is a forearm and it will be placed just medial to the PSIS. The aim in this adjustment is to create a long axis distraction of the segment. The first step is to approach the couch with your feet pointing in the direction of your line of thrust. Your next aim is to position the patient so that you can come comfortably towards you in a sequence such that your forearm is loose and that your centre of mass is over the top of your forearm. So if we look at it in practice, I get my stance, I select the type of stability that I want to use so that I use a thigh-to-thigh contact. I will place my primary contact on, I will roll the patient as a unit and place my centre of mass forward to my primary contact. From here I can add my segmental lockup and then I will slowly preload the patient by using body weight displacement from front leg to back leg.
Can you see what I mean now about that tissue stretch and that pre-tension? The other thing to note is that he grabs, it looks like his hand is on the patient's spine. It's not really. You can lift the hand off. It's not actually making a contact or making a difference. All of that pressure comes through that forearm, not the elbow. You drag it with that fleshy part of your forearm and he drags it into his own body. Now, he tries to get his elbow as close to his body as he can so that his whole body will move as one unit, okay? You're never going to be able to move bones or make a difference to these lumbar areas without incorporating some kind of body drop, okay? That is key for these adjustments. So you watch how Steve manages to incorporate his arm holding that tension, taking that body drop and keeping his body where it needs to be so it's the most efficient.
I must start forward enough so that I can create the displacement and still have my centre of mass forward to my forearm, so that then I can drop in a simple plane directly from front leg to back leg. So if we put that into practice, we segmentally lock, we displace, we lean forward in the opposite direction to thrust, find our final lock and drop. Alright, so I'm approaching the patient with my feet in the right plane. I have rolled the patient so that my arm and body is now connected. My centre of mass is over the top.
Okay. Now, what is the segmental contact point on the patient? Come on. So we did this one before. So what's the segmental contact point for this adjustment?
It's not the forearm.
No, where you touch a segmental contact point refers to the point on the patient.
Yep, so Hannah, it's your forearm. Where does your forearm sit or what contact
The
is it?
sacral ala or whatever
That's right.
it's called.
That's right. Okay. And so then what is your contact point? What is the practitioner's contact? What are you using?
Thigh to thigh.
Well, that's the stabilization. But what part of
your
body?
forearm.
That's right.
Fleshy
Flesh
part of your
and
forearm.
That's right. Okay. Does anyone have any questions about that? What's the line of correction?
Inferior.
Okay. And what would the listing be?
Lateral flexion restriction.
That's right. Okay. Can you see how this is all tying together now? So clearly, we're not going to be judging you on how you're going to be able to perform this, but your ability to understand what your corrections are going to be, what your contacts are going to be, is important. Okay? Any questions? Oh, I don't want to see it again, Steve. There we go. Okay, so our next one is our lumbar BLR pisiform contact anterior adjustment. So what's the point? What is this adjustment? Is it a short lever or a long lever?
Short lever.
Short lever. And what is the line of correction?
Anterior.
Anterior.
Okay, and what is the segmental contact point for this one? So what point are you touching on the patient? Just say it was, we're going to be contacting L5. What part of L5 are we going to be contacting? Are we going to be contacting the spinous process?
Is it the mammillary?
Yep, that's right. The mammillary. That's our contact. And so we know now that we've got a pisiform contact that's going to be our primary. We're going to be contacting the mammillary process, and that we're going to be going, our line of correction is anterior. Okay? So our adjustment mechanics, we know that this is a high velocity, low amplitude adjustment. We know that it's short lever, and we know it's resisted. And what's the recoil?
Slow passive.
Okay, beautiful. Now, for an anterior adjustment, what motion is that going to be correcting? If we had a restriction, what kind of restriction would it be?
Is it a rotation restriction?
That's right, it's a rotation restriction. So our static palpation findings would either be an RP or an LP listing. Okay? Now, so for this one, do we know if it's involved side up or involved side down?
What was that? I missed that. Was that a question?
So for the, yes, it is. So for our inferior adjustment, do we have the patient, which way do we have the patient lying? So if it's a LI, do we have the patient left side up or right side up? It's what we call an involved side up. So if it's a LI, we would have the left side up.
Right side up?
Yeah. So for this one, it's an involved side down. So if it's an RP, we have the patient's right side down. If it's an LP, we have the left side down.
Below.
Yeah, that's right. So Scott is got the patient same secondary, so we're going to have that superior contact and that posterior pressure. But the primary contact this time is going to be away from the body, and you can see. Okay, so let's just say we have an L4RP. Okay, so that means that we're contacting which segment?
The sacral.
Nope, if it's an L4 listing.
L5 then.
L5. And what are we contacting on L5?
The mammillary process.
That's right. Now, which side, if it's an L4RP, which side is the patient laying on?
Laying on their right side, so the left side is up.
That's right. So you can see here, our primary contact is going to be contacting on that mammillary process of the segment below, and it's going to be creating that A to P rotation to correct that anterior line. All right, does that make sense? Everyone's looking a bit lost this afternoon.
That makes sense.
Okay. Let's get to the next one. Now here Scott's going to show that adjustment. Sorry, guys, it says it's coming.
Okay, after we've positioned the patient with a BLR position, side posture position, we're going to do our first adjustment today, which is our pisiform anterior thrust of the lumbar spine. This is a resisted adjustment, so if we want to affect the L4-5 joint, we're going to contact the mammillary process of L5. If we were to affect L5, we contact the sacral alar. So let's affect the L4-5 joint. We find the level that we want. We use thigh flexion. We use thigh flexion to create some opening of the joint at the back here, and then we combine that with some counter torque with the secondary and the primary. And when we feel that we've got a little bit of pretension, we roll the patient forward as a whole. As we do that, we take our thigh-to-thigh contact and stabilise firmly. Basically, the patient should not be able to roll forward, even if we push them, unless we allow that to occur. When we actually thrust, we're going to want to drop away with our body like so.
Okay, Scott was just mentioning about the patient being able to roll. That's what the thigh stabilisation is for. It's basically to pin the person to the couch so that they don't fall off the couch. Okay, that's what that's about.
All right, so we've taken a basic pretension, we've taken our body position, and the last step is to take our primary onto the mammillary of L5 with a skin slack or tissue slack of medial to lateral and a little bit I to S. From here, we feel into the last little bit of pretension using the shoulder, using the leg, and using our primary contact. Patient we provocate first. Is that okay there, Rick? Patient takes a deep breath in and out. Preload and drop. Provocate, feeling okay. Deep breath in and out.
Okay, how does everyone feel after watching that? Does the mechanics make a bit more sense? Yeah? So what's our primary contact? What part of the patient, of the practitioner's body are they using to do the adjustment?
Pisiform.
That's right. What is our line of correction?
Anterior.
PA.
Yep, anterior adjustment. And then what is the listing that we could have?
Rotation restriction.
Yep. So which is what kind of listing? Give me a static
RP
listing.
or LP.
That's right. Now, what kind of adjustment is it? Is it assisted or resisted?
Resisted.
Resisted.
So if I have an L4 listing, what is my contact point on the patient?
L5.
Mammillary contact.
Yeah.
Okay. And is it involved side up or involved side down?
Involved side up.
Down.
Down.
Inferior is up and anterior is down. Okay, so if we have an RP, we are right side down.
Oh.
Okay. Any questions?
Yeah, I've got a question.
Oh, okay.
When you're doing spinal adjustments, I've noticed that the patient's asked to like breathe in and breathe out.
Yep.
Why is that?
Part of it
Is it so that they're not holding tension?
Yeah, part of it is so that they let go of all their tension. And, you know, like if you've put your hands on your own chest, right? So when you breathe in and you feel your rib cage expand, and then as you let it out, if you follow that movement, you can take a bit of that slack out rather than going against the breathing.
Yeah. Okay.
So part of it is to kind of get them to relax, but as they breathe out, you kind of, because their rib cage deflates, you can take the tension out. So it helps you basically, because before you do any adjusting, you've got to get to that point of integrity, right? Otherwise, you're going to be having to do a high amplitude adjustment, which is not what we want to do. The speed allows us to do a lower amplitude, but it's also the pre-tension that allows you to do that. Okay? So it just helps with all that pre-tension work.
Okay, thank you.
That's all right. Okay, so here's our last table for the day. So we've got our lumbar, BLR, pisiform contact anterior. Can someone tell me about adjustment mechanics? Could someone tell me whether it's a short lever or a long lever adjustment?
So short lever.
Okay. Is it assisted or resisted?
Resisted.
Resisted.
Okay. What is the segmental contact point? So remember, the segmental contact point means the part of the patient that we're touching.
The mammillary
process.
That's right. Now, is this a direct contact or an indirect contact?
Direct.
Direct.
That's right. Ta-da! Okay, so what is the adjustment effect going to be on an anterior, for an anterior adjustment?
Improved rotation.
That's right. And then what is our motion listing?
Rotation restriction.
Yep, that's right. So we did our RPs or our LPs, right? Beautiful. Okay. So lumbar, BLR, forearm contact, inferior adjustment. Tell me about the adjustment mechanics. I'm going to start calling on people because you're all being a bit too quiet. Okay. Chang, can you please tell me whether this is a short lever adjustment or a long lever adjustment? You there, Cheng? Unmute yourself, hon.
Can you hear me?
Yes, I can hear you now.
Oh, it's long lever.
Long lever, perfect. Gurjot, can you tell me whether this is an assisted or resisted adjustment, please?
Resisted?
Yes, that's right. Okay. Zhao Yu, can you please tell me? So remember, the SCP means the part of the patient that...
L5?
For the inferior?
Yeah.
No, for this one, it's going to be the... Does anyone else know? Chuck, do you know what the segmental contact point is?
The S word I can't
Sacral ala.
Yeah.
Sacral ala, that's right. Okay, so remember, for our inferior adjustment, no matter whether the listing is at L1 or the listing is at L5, we are going to be contacting the sacral ala. Okay, so on that point, is this a direct contact or is this an indirect contact?
Indirect.
That's right, because we're using that soft tissue bridge to create that tension. Okay? Now.
Rach, I have a question.
Yes.
Sorry, this might be a silly question, but because you're contacting the sacral ala, does it mean that, like, when you do the adjustment, then you're affecting every lumbar?
No.
So, you know what I mean? Like,
yes, absolutely. So what we do in practice is there's a way to localize that to one segment at a time. Okay. At this point in our careers, we don't particularly care. We're not going to be saying, we would never be marking you on, say, please, can you get L3 to move only? But ideally, eventually, we wish that you learn that a bit later on. But so basically, by creating that flexion with the bent knee, you can lock and unlock further joints.
Okay, so right now we're learning just contacts.
Yeah, that's right.
Okay.
Okay. So good question though, because I'm sure everyone else is wondering that too. Okay, and sorry, and so our adjustment effect is going to be what? To restore what?
Lateral flexion.
That's right, restoring lateral flexion. And so our motion listing would be?
LI or RI.
That's right. Okay. Beautiful. All right, team. We've got everything done today. I wasn't too slow today. Now, what I'd like you to do before our next class is go through these tables, okay, and see if you can put all this together in a puzzle. Find your listings, you go your assessment. Now, what adjustment would I do to correct this? Does that make sense? So you can see how Chris is... Yeah.
Sorry, could you put that one back up? I didn't write it all down.
Oh, sorry.
All good.
I'll get it back for you. Yes, so if you can see how this is all going to correlate together, right? We're giving you how to assess something and how to correct it. So as long as you can understand what you should be and how you are going to assess the correction.
Honestly, this helped me understand a lot more.
Okay. Can you see that better now, John?
It hasn't loaded up yet.
Oh, okay. Sorry, my kids have just invaded. Okay, is that coming up for you now, John?
Don't worry, I can check it out with the recording or whatever.
Okay. All right. If you have any questions, please feel free to shoot me an email. I'm happy to answer stuff that way too, because I know today has been a little bit techie glitchy. All right, we're done for today, guys. So enjoy the rest of your week, and we will see you on Friday.
Thanks, Rach.
All right, see you guys.